Hi, this is Elliot Fishman, and in this talk, I'm going to get to the real basics and basis of CT, looking at protocols and protocol design, sort of how we do it. There's no doubt that when you look at CT and you look at your accuracy, it really is dependent on how you do the study. And we've discussed this literally in every single talk we always give, whether it's pancreas, liver, kidneys, chest. Everything is based on technique. There's a good quote I saw: people trust their eyes above all else. Most people see what they wish to see or what they believe they should see, not what is really there. Well, as a radiologist, we know that would be a real problem. You need to see what is there. We learn, and the reason we do CME, the reason we listen to lectures or read, is because we learn that we can continually learn. Life is a continuing learning process. And in fact, in radiology, we know that you really only recognize things that you're looking for, that you know to find. And where you find things is a matter of training. So you remember those Waldo cartoons when we were kids. And if I ask you to find Waldo, it's really hard. There's so much noise in this picture. It makes it very difficult to find Waldo. Where is he? And it's always interesting. Once you see Waldo, it becomes very obvious. And so if I put a circle over Waldo, there he is, clear as day. And that's very much how we think about CT or imaging in general. Once you know what to look for and you know what's important amongst all the noise, it becomes something that's easy to find. And so finding things become critical. And it's also important that we don't kind of misunderstand what we're seeing. A few of those visual perceptions, like this beer can or the cigarette smoke or trying to catch this airplane, make the point that sometimes things aren't always what they seem to be. One of the issues we have, and one of the things we always try to do better, is avoid errors. And a number of articles have looked very carefully at errors. And when you look at CT, and you look at most imaging, but surely CT, the majority of errors are false negative exams where interpretation occurs because we don't see something. Usually when you see a finding, you can come up with a differential diagnosis which may not be perfect, but at least it's close. But when you look at this list, these are the things that are commonly missed, from pancreatic masses to PEs to vascular abnormalities, bone lesions, and on and on. Now, if you look, another article came out more recently. Majority of errors made on CT were errors of underreading where the finding was simply missed. And this has been true with mammography, this has been true with MR, this has been true with angiography. And it's somewhat impressive. This article goes on to talk about the interpretation error rate in practice is between 3 and 4%, which seems awfully high. However, of studies that contain abnormalities, the error rate could be higher, in the 30% range. Now that's, to me, a little bit scary. So that means if a study's normal, you're probably going to read it correctly. If the study's abnormal, 30% of the time you're going to be wrong. You're going to miss the finding. So that's really a scary rate. I think it's a lot lower than that, but nevertheless, it does say we all have room for improvement. If you look at CT, a lot of our improvement comes on the basis of technology. When you look at a 25-year span, when spiral CT was introduced, to today where we have dual source scanners, where so much focus is from the last couple of years on low dose scanners, but trying to make high quality with low dose. So technology has been a good friend to us in CT. Now these days, if I ask by a show of hands, almost everyone has 64 slice scanners. People have more than that, but I would say that state-of-the-art or standard practice is really 64 slice CT. And 64 slice CT was very important because it was really that first time where you could have isotropic data sets. We're able to get large volumes of data with isotropic conditions, and that really changed everything. It made multiplanar and 3D imaging somewhat mainstream. It allowed us to do it on every single patient. It also allowed you to get quality data sets in a very short period of time on every patient. And as we know, from 2005 on, we've seen constant improvements, but that 2005, to me, that was the barrier. Now, the one thing about that barrier, of course, when you look at the total number of slices, it's really changed, right? That when you went to 16, you reached 1,000 slices. When you went to 64, you had multiple thousands of slices, which means we need to do things differently. And in this talk, I'll also look at how we do things differently and how we should do things differently in order to optimize the information we gain and minimize the potential for error. Now, one thing I need to at least bring up, and I won't go into great detail, will be radiation dose. And radiation has been the big focus of CT for about a decade now. Now, the history of X-rays is a long history. In the 40s, 30s, we were shoe fitting. Not that radiologists were doing that, but people were getting their feet X-rayed to get better shoe size. And some people swear their shoes never fit as well ever since things changed. But it was really in about 2007 that the real interest in radiation hit the public, I would guess. We always knew that we were trying to minimize the radiation dose, but in 2007 there were two articles that really I think impacted everything we do. This article by Einstein, organ doses range from 42 to 91 millisieverts for the lungs and 50 to 80 millisieverts for the female breast. This was looking at coronary CT angiography. It spoke about how a coronary CTA could increase your cancer risk for young patients as well as for old patients. Now, there was nothing looking at the advantages and how it would improve quality of life, but it really focused on this potential for radiation issues, and this was all simulated dose, but nevertheless, that was there. And the article by Brenner in New England Journal of Medicine, which came out amazingly during RSNA week, which had a number of assumptions. If you look at, it has been estimated that 0.4% of all cancers in the U.S. may be attributable to radiation from CT studies. Where was that from? By adjusting the estimate for current CT use, 2% of cancers are caused by CT radiation. And talking about then saying when a CT scan is justified, the risk is relative. However, it's true that 1/3 of all CTs are not justified, and it appears to be likely 20 million adults and 1 million children are being irradiated unnecessarily. Now, where exactly did you get these numbers and 1/3 of all CT scans are not justified? That was just, a real surprising article in the England Journal of Medicine, which tends to focus on science. This was like a political statement. But nevertheless, it was picked up by all of the newspapers, and it really did make us refocus. So I guess that's the positive thing, on making certain that our scanners were delivering the lowest dose possible. And vendors, ever since that time, have put a great focus on developing new scanners with new technology for lowering dose. Now, no matter how low the dose goes, it's never going to satisfy people. It's always going to be something we're going to deal with in radiology. You remember the issues with the airport X-ray machines, where if you went through that 1 million times, it was the same as flying to California, perhaps, or less. But nevertheless, people are never willing to say anything above 0 is satisfactory. And so you're always going to see articles, and it's always interesting to me about how articles come out. And I'd like to show this pair of articles. This was in the New York Times. I'll show you 2 articles 3 days apart. This first article in the personal health column talks about how medical radiation risk is often overlooked, okay? And you could see that there's a statement in there which is really inflammatory as far as I'm concerned. Doctors in private practice who have bought imaging equipment tend to use it liberally to recoup the expense. Same goes for hospitals a few miles apart that needlessly duplicate equipment so they can boast of having the latest and greatest to detect disease. Doctors ordering tests suffer no adverse effects, and patients feel they're getting the most from modern medicine. Well, it's interesting, and then they go on that patients may be surprised to learn that some of the newest uses of radiology imaging, including CT of the coronary arteries to look for calcium buildup, have not yet been tested scientifically. Experts estimate that the use of coronary artery scans could result in 42 additional cases of cancer for every 100,000 men who have the procedure. Okay? And 62 cases for every 100,000 women. Well, that's kind of stretching the truth a little bit. Remember that the dose from a coronary calcium score is well under 1 millisievert. Average background in Baltimore is 3 to 5 millisieverts a year. But less than 48 hours later, not in the personal column, but in the science column of the New York Times, it recommended predicting heart attack risk, a calcium test may help. It recommended that everyone should get a calcium test, a calcium score, because it will help prevent heart attacks by stratifying risk. So again, same newspaper, less than 48 hours apart. One says it's wonderful, one says it's scary. So again, it's something we live with. Again, New York Times a couple years later, we are giving ourselves cancer, written by a radiologist in part. Nothing new in this article, but just an opinion page, an opinion which was not really widely held and really kind of stretched the truth. And sure enough, there's a opinion page from the New York a couple days later, again from the RSNA and ACR, going and rebuting that information. And of course, it never changes. This past February, there's an article in Consumers Reports about the dangers of CT scan. Now, Consumer Reports, last time I looked, before I canceled my subscription, used to look at cars and radios and TVs and tell you what 45-inch TV screen to buy, not going into this CT scan and radiation dose. If you read the article, it's all quotes from articles that have been published over the prior 10 years. It says nothing new or nothing important, but again, it creates a little bit of fear in our patients' minds. So it's something that we're just not going to get around, and I think as radiologists, it's very important for us to know enough about radiation that we could be good informers to our consumers, to our patients, about what the risks are, and to really make sure that people understand that we are minimizing the risk to them, and the amount of information gained is indeed substantial. Good article by Melvin Cohn, who's a pediatric radiologist, who said there are two risks for radiation. The first, which is well recognized and much talked about, is the risk of radiation exposure and the increased incidence of cancer. However, the second little discussed risk is missing a diagnosis because of suboptimal image quality as a consequence of radiation exposure that's too low. And he goes on to say when performing CT, one needs to maintain a balanced perspective between the equally important risks of radiation and the consequence of erroneous diagnosis. And that indeed is a good point. You remember we had this ALARA principle, as low as possible. Well, now it's changed to as low as allowing you to get the information you need. And that's really a balance. You can make a very low dose scan, but it also has very limited information and you have misdiagnosis. So again, it's a balance. A good article on this whole issue from Coakley, who's now up in Oregon, spoke about the number of things you need to do to make sure your dose is as low as reasonably possible. Again, thinking about your protocols, thinking about the number of phases you do, making certain that the radiation that you choose for your scans, whether it's KVP, MA, table speed, gantry rotation time, is really optimized to get the best study at the lowest dose. So that brings you to the point, how do you design a CT protocol? And that's something that you constantly need to be doing. I always ask the question in meetings, how often have you changed your protocols? How often do you look at your protocols? People rarely raise their hand because people haven't checked their protocols. I think it's very important at a minimum every year to look at all of your protocols, make sure they're up to date, make sure the protocols are where you need to be, make sure their doses as low as possible, make sure the protocols are well designed, there's no confusion. If you do it once a year, I think you'll be in good shape. On CT as us, we update once a year, and you're going to see a lot of updates very soon from us, literally in the next several weeks. When you look at the protocols again, as we've spoken with many other articles, you need to make certain that you have all of the correct phases. You don't want one too few phases that you might need, but you don't want one too many. You want to make sure your contrast injection rate, volumes, and timing are ideal. You need to know about oral contrast, IV contrast, whether you need to use rectal contrast, whether you need contrast placed in the bladder. All of those things should be designed. So if you have a pancreas protocol, is it water? Is it positive contrast? You use IV, how fast do you inject? How much do you inject? You have pelvic trauma, you're worrying about bladder injury, CT cystogram, how much contrast do you put in? Do you get non-contrast? Do you get delayed? What exactly do you do? When you design a CT protocol, all of these parameters are critical. The KVP, is it 100 or is it 120? What's the patient's size? For many patients under 170 pounds, 100 KVP is great. When you go from 120 to 100 KVP, you decrease the dose by a third. That's one of the easiest things you can potentially do. So again, it's very easy to do. interscan spacing, reconstruction algorithm. You need to answer these questions for every single study. When you look at CT as Us, which is part of this series, that's what you'll find. So if I take a simple protocol, and again, you don't need to read the small print, but you could see for a suspected pancreatic mass, we show the phases that are possible, all 4 phases, and we show that we only do arterial and venous. We show the technical parameters. We show the effect of MAS, how we do it. We show pitch. We show scan direction. We show the contrast type. We show how much we use. We show slice thickness, reconstruction spacing, algorithm, and everything else that becomes important. And that needs to be done for every single protocol. You don't want to have 1,000 protocols, but you probably need somewhere in the range of 100, and they need to be very precise on each one of your scanners. And at times, many of you have different scanners, and you need to make certain that the protocols are adapted specifically for each of the individual scanners. The other thing that's very important to realize is that even when you have a protocol, it's not a perfect fit for every patient. When you look at hematuria, there are a number of causes of hematuria, but whether a patient has macroscopic or microscopic hematuria, that will change the risk of the patient having a tumor. Also, looking at the patient's age, the likelihood of a cancer in a patient with microscopic hematuria under 30 is very low, and the likelihood of a cancer of a patient over 60 with macroscopic hematuria is very high. So we need to tailor the algorithm for the risk, including patient's age. CT urography can be used as a first-line diagnostic or as a problem-solving test this article speaks about, and it also mentions for first line it should be reserved for patients with a high pretest probability of malignancy, that is 50 years or older with macroscopic hematuria or the presence of other high-risk factors. And again, it's very important to make certain you're scanning differently for a 10-year-old or a 20-year-old or a 70-year-old. So again, just saying hematuria on your scanner protocol is not going to be enough. When we speak about oral contrast, it's the critical things: type, volume, and timing. And theoretically, you can give water, oral omnipaque solution, volumen, and then you can give IV contrast. And again, if you speak about the oral contrast for a moment, what do we do? How long do we wait? An article by Lee made the point that some sites don't wait at all, and some sites give contrast overnight. It's really a kind of a conflict. For many things, you would love to give it overnight, but quite frankly, it doesn't work, particularly with outpatients. You can't have patients coming for contrast and going home. It doesn't work in a busy practice. And also now, in the ER setting, the ER docs, as you are all aware, don't want to even wait 30 seconds. They want to increase the throughput time because they get paid based on throughput, and often it compromises scan quality. Now, can you eliminate oral contrast? I mean, for stone protocol, you don't need oral contrast, but for many things, oral contrast is critical, so it's this balancing. In terms of oral contrast, when we use positive contrast, we use a solution of Omnipaque 350. That indeed is really an ideal contrast agent. If you mix, basically what we do is we take a gallon of water, we add 100 cc's of Omni 350. For every 10 cc's in a gallon of water, you get approximately 20 Hounsfield units, so it has a density of about 200 Hounsfield units. That's perfect. If you take Omnipaque and you put it in water, it has no taste. It's taste neutral, and so patients have no problem drinking it. When you have barium-based products or other type products, the old gastrographin-based products, patients have a hard time drinking it, so it takes forever for them to drink the contrast. With oral Omnipaque, you put it in nice cold water, patients drink it right down, 1,000 cc's, there's no problem. There was a taste test done, kind of like the Pepsi versus Coke. 81% of patients preferred dilute iohexol compared to 54 patients who preferred dilute sodium type solutions, okay? So you can see the patients prefer it. The other thing with oral Omnipaque, it's easy to mix. It gives very nice studies, and so if you're looking at this case of lymphoma, very nice opacification of the bowel. The oral Omni has a bit faster transit time than other solutions, which can be very helpful. If you're looking at things like perforation, in this case, oral Omnipaque in the peritoneal cavity does not cause peritonitis. Gastrographin can cause peritonitis. So oral contrast with Omni, if it's aspirated, there's no problem. So it's a very, very safe contrast agent, And you can see here there's pneumoperitoneum, and you can see the site of the perforated gastric ulcer, very nicely shown with a positive contrast material. So positive contrast material is something we use routinely in our oncology patients, following up cancer of the pancreas, cancer of the colon, lymphoma, and the like. Also, if you can't give IV contrast, you'll always use positive oral contrast material. There's a very tiny risk, theoretically, of a patient with severe reaction to iodinated contrast with PO. Usually with PO, it's so dilute that it's not going to be an issue. There's only a few reported cases of reactions. If you're really concerned in those cases, I would use a barium-based solution. So that's pretty rare, but it's something to keep in mind. Now, the next thing we can use is water as a contrast agent. We do like using water when we're doing CT angiography. It allows you, for example, in this case of Crohn's disease, to get a very good look at the patient's small bowel. You can see not only the small bowel, but the vessels. The interface between the vasa recta and the bowel wall is ideally shown with water. With positive contrast, you don't quite see it as well because the interface is lost. And if you're looking for things in the mesentery, if you're looking for any type of vascularity, where you want to do vascular maps with CTA, there's no doubt a neutral contrast agent is the best. Some people do use oral Omnipaque and dilute it even further, so the solution measures, let's say, 60 Hounsfield units instead of 200, which means you put in simply 30 cc's of contrast into a gallon of water. And again, that can be done, and it's something to possibly consider. But you can see when it's looking for vascular maps, a neutral agent is really going to be ideal. It creates no artifact or problems. The other time it's very, very helpful, of course, to use water is if you're looking at things like GI bleeding. Here was a patient with a potential GI bleed, and you look at the axial images, and perhaps there's something in the patient's right colon. It's not that convincing. But look when you go into the MIP, look at those abnormal vessels off the ileocolic vessel involving the cecum and ascending colon. Beautifully seen, okay? And this is angiodysplasia. Very nice example. The same thing in this case of GI bleeding. If you have GI bleeding, you must use a neutral contrast agent or no contrast agent at all. Positive contrast can be confusing. In this case, this was initially read as negative, but look at the patient's left colon. You see the high density area there, which is shown better on the coronal. And it's even shown better as you go from arterial to venous, where the active bleed is really well seen. So one of the rules we have, for example, in terms of protocols, when you're looking for GI bleeding, you always get arterial and venous. Many cases, arterial is great. In some cases, we only see the bleed on the venous. If we see it arterial, we invariably see it venous as well, and often it increases from arterial to venous. It becomes much more obvious. Some people do non-contrast scans first. They're concerned about the possibility of high-density matter in bowel simulating a bleed. What we did is, in order to minimize the dose, is we got rid of the non-contrast and we do arterial and venous. Most people were doing non-contrast and arterial. By doing arterial and venous, you have the advantage of having that venous for detecting late bleeds. Also, in my experience, if there's a bleed present, it always changes between arterial and venous, more or less, but it will surely change. If you had foreign matter, it would remain identical between the two phases. CT enterography with volumen was something that was very popular. We were never great fans of it. It uses methylcellulose, and patients often got diarrhea. The way it works is it's 450 ml pre-mixed bottles. Depending on the protocol and the site, you either use 2 or 3 bottles given every 10 minutes, followed by water. What volumen does is, in a sense, gives the patient diarrhea because it brings fluid into the bowel. One of the issues with using water as a contrast agent is in the normal patient, when there's no obstruction, water gets resorbed quickly, so it's very hard to distend the distal bowel. With volumen, you bring fluid into the bowel, so you create somewhat of a diarrhea in that patient, which is what this looks like. But again, it's not as perfect as it used to be. They've changed the solution. Our experience has not been all that good, and we rarely use volumen. In this case, we use volumen. Again, water would work fine in the proximal duodenum. This patient had polyposis syndrome, and you can see the multiple polyps which are enhancing. So that works very, very nicely. Now, in terms of looking at risk reward, one of the things that then comes up is IV contrast material. To me, IV contrast is critical on every CT scan. There's no ifs, ands, or buts. I know stone protocols, no contrast, great. Otherwise, to me, IV contrast with fast scanners, multiplanar reconstruction, and 3D imaging is critical. In the ER setting, the idea about ruling out appendicitis non-contrast or abdominal pain non-contrast is, as far as I'm concerned, crazy. I like to give water and then IV contrast material. We can turn the patients around in 15 minutes. It's no problem. A lot of our protocols and information about protocols you can get online on CT is Us. You can download this app, which is in the Apple App Store for your iPhone or iPad, and it's for free. What a bargain. Everything you want to know about contrast is in there. But let me just go through some of the important things about IV contrast. So one is, if you ask me what I'm concerned most about in CT, what are the scariest things to me, I do worry about contrast reactions, but with contrast agents like Visi and Omnipaque, it's rare, knock wood on the podium, it's very rare to have any issues. What worries me is with fast injection rates is contrast extravasation. And yes, contrast extravasation with non-ionic contrast is not the same as it was in the past with ionic contrast, which was a total disaster. But the problem with non-ionic, it's not painful. So if a patient extravasates, they don't tell you, oh my God, this hurts. With ionic contrast, with 1 cc, they would be screaming. Even if it didn't extravasate, they'd be screaming. But with things like Visipaque and Omnipaque, you don't have any pain. You only know the patient extravasated when you don't see contrast in the scan and you come out and they got a big bump on their arm. So to us, it's very critical. Communication between the tech and the patient is critical. We do not have our injector boxes and our MedRad injectors in the scanning room where the technologist sits and does the scanning. The boxes are next to the patient. We want the tech to be out there with the patient when the injection happens. It's rare for the injection extravasation to occur the last 20 cc's. It's not like 80 cc's goes in well and 20 extravs. That's pretty rare. What usually happens is 5 cc's go in, then you have extravasation. Now, in most of our cases, we're scanning at 30 seconds. So the tech stays in the room. They could be in the room for most of the injection, having their hand at the injection site, making sure there are no issues. And that is the way to do things. Now, people do ask, does faster injection rates result in higher extravasation rates? There are a number of different questions that people ask, but the answer really isn't the rate of injection. It's really where you put the IV, how good you are at starting the IV, and how careful you are with the patient. But there are a number of different factors. This article by Wiedbach looked at some of the things that affect extravasation, and they showed that performing high flow rates with low diameter IV catheters, which means 22 gauge, and the location of an IV catheter in the hand was associated with higher extravasation rate. And that's a very good rule. If you have to use an IV in the hand, you better inject slower and you better watch carefully. And when you use smaller needles from classic needles, you have to be very careful. Yes, you can inject faster with 22 gauge, but that's a much higher incidence of extravasation. And that's a very, very important point to remember. Okay? Now, when you're using 18s, it's harder to place because it's a larger needle, but you have extravasation rates that are much lower. But there are ways around this. Again, extravasation rates were also higher in older patients, but that's not a surprise. Their veins are a little bit more fragile. Cancer patients, you also worry a lot because they're on chemotherapy. A lot of their veins have been used over and over, and their veins are indeed more fragile. Ideally, we always like to put the needle in the antecubital fossa. That's the preferred access site. The ACR manual says that if a peripheral hand or wrist venipuncture site is used, a flow rate should not be greater than 1.5. So you can see the ACR really looks at that very carefully. Now, one of the things we know, and where our problem comes in, with our fast scanners, we want to inject 5 cc's a second. With faster injection rates, we have better timing, we have better ability to create vascular maps, CT angiography, and everything else we need to do. So the question is, how good are we at starting IVs, and how often do we have problems? Pam Johnson and Gail Christensen did an incredible study looking at these patients. And what they found was that when you use experienced IV starters, and at Hopkins we have an IV team, nurses, an IV team that starts the IVs, it's not the technologists, it's not the physicians. These people are really good, that they're able to know what size vein, what size catheter will fit in the vein. So it's not that often they'll put an 18 in and then have to go back and put a 22 in. But on the other hand, what they often will do is use a smaller needle because they feel a large needle will not work, and then you don't have the injection capabilities that you really wanted to have. And so in oncology patients, for example, nearly a third of patients in this study were getting 22 or 24 gauge needles, which is not really what you want. Well, the good news is things have changed. There is a new needle that has come along by Beck and Dickinson, the Nexiva needle. And what that is a fenestrated catheter, okay? What does that mean? Well, when you think about its typical needle, all IV needles are the same. Come in different colors, but they're the same. There's a hole at the bottom. And so you have an 18, you have a 20, 22, 24, even a 16. But there's a hole at the bottom, and the contrast shoots out the bottom. With this fenestrated catheter, it's kind of like a space shuttle. You have multiple side holes. So instead of everything going out through one hole, it goes out through multiple side holes. So several things happen. It's easier to get a fast flow rate through a larger catheter. And also, you're not hitting the back wall of the vessel with all that pressure. Often the pressure on the back wall will cause the vessel to break, particularly in older patients, and you have extravasation. And so in this study, what we're able to do is look at the standard 18 gauge versus a Nexiva 20 gauge. And what you found was that the 20 gauge performed similar to the 18 gauge in terms of the ability to inject contrast and quality of studies. And so what happened was you never need an 18 gauge. There's never a need for an 18 gauge needle, because when you look at these BD diffusics, look at the flow rates, okay? You can take a 20 gauge and get up to a 10 cc or 10 ml per second flow rate. Even at 22 gauge, you can get 6.5 cc. So it's indeed very impressive. And since we're injecting typically at 5, the 20 gauge is perfect. You can even use a 22, but we're using a 20 because it's easy to start. And again, 10 cc's, and I'm told by the company off the record that, and obviously it's no surprise, when the FDA approves something, they approve a number like 10, but probably it can do 12 to 15, which we never will use. But again, this makes our life very easy. There's a slight learning curve for this needle. The cost is minimally more expensive, but if you think about it in the big picture, between sticking once, the speed of putting the needle in, and not messing around, and that takes nurses' time or IV people's time, it's really very, very cost effective. And in fact, we're writing an article about that. So it's very important to have the right catheters. So that indeed becomes very, very important. Now, these newer catheters are ideal up to PSI of 325, so it works very well. So it's important, therefore, for you to understand what catheters you have and why you have them, who started the IVs, how good they are, what IVs you need. That should all be part of your protocol. It's also important to recognize, and you know about this with hospitalized patients and also cancer patients, when they get central lines, often they have limited access. You want to make certain that the lines that are placed in patients are these power picks, that they're made for CT. Often they have a little purple label on them. It says 5 cc's or less, but it's CT approved. PICC lines easily rupture. With classic PICC lines, people would inject and the lines would rupture. So again, these power picks are indeed very important. The use of them becomes very critical. I think it's very important that you speak to, if you're in a cancer center, speak to the people in oncology and ask them what lines they're placing. Make sure they're using lines that you can use, because invariably if a patient can have a central line, they're going to get a routine follow-up CT, they may get a PE study, they may get some other vascular study. Having the right central lines becomes very important. So when you think about it, when we talk about CT, there's so much beyond the actual reading of the scan that becomes very, very important for us to do. Now the next thing is, you got the line in place, you have to choose a contrast agent, okay? And contrast selection is critical. There are many different contrast agents. I'll just tell you what we do at Hopkins, and we've done since I started here a long time, more than 30 years ago, a long time ago. We use either Omnipeg 350 or Visipeg 320. That's it, okay? We are concerned and always have been concerned and will be concerned about the risks to our patients from contrast agents, and we want to minimize the risks. There are lots of charts. We still use creatinine levels. Many people use GFR. Either one works. The GFR became very popular with MR. The key thing is trying to figure out the risks of individual patients. And although there are many charts like this one, the risk-reward is often not readable from these charts, and I'll cover some of that information. The issue is contrast-induced nephropathy. That's the concern. It's the third most common cause of hospital-acquired renal failure. But if you look, it's rarely CT patients. It's more commonly angiography patients, particularly cardiac-type patients. And again, one of the important things to remember is in CT in the old days, when many of the articles were written, you were using 150 to 200 cc's of ionic contrast. You were putting the patient NPO after midnight, okay? High volumes, old contrast, and putting the patient NPO. These days, we have the patient drink lots of water. Remember, the patient was put NPO midnight, they may not get a scan for 12 hours. Dehydration is one of the #1 risk factors to me for getting SIN. Okay? Now, the measurement of contrast-induced nephropathy, there were two different rules. It was defined as an increase in creatinine from a baseline to up 25% or 0.5 milligram. The problem with that is, of course, is the timing when you measure. Also, as I'll show you some articles, people have looked and show that in a normal patient, in a patient who doesn't get IV contrast, the creatinine levels for a hospitalized patient or any patient is not a perfect flat line. It goes up and goes down. So it's really hard to judge exactly what is going on any specific patient. There are certain risk factors that we know about. I worry about patients with diabetes, whether or not they have normal renal function. I worry about dehydrated patients. I worry about myeloma. We worry about patients who are older. We worry about oncology patients because they're often on multiple different drugs, and we don't know the risk for each of those medications since they're on so many. And now hypertension and metabolic syndrome are two additional risks that people speak about. Question, do I need to get a baseline creatinine level before CT? Some people, some institutions will say every person needs to have one. Some institutions will say if you had one within 90 days, that's fine. Typical rules are over age 60, a patient with history of any type of renal disease, history of hypertension requiring medical therapy, history of diabetes, or a patient on metformin. So that may be one rule. It's interesting, people are rethinking this whole issue of what's a good creatinine level. Some people worry at 1.5. We worry at 1.8, but I will tell you that I will give contrast into the 2.1, 2.2 level. If it's necessary, I'll lower volumes. These articles now are really suggesting that we tended to overestimate the worry. Article by Newhouse. Creatinine level increases in patients who are not receiving contrast as often as it does in published studies of patients who are receiving contrast. The role of contrast material in nephropathy may have been overestimated. As I mentioned, people have done studies. Two people in the same room, one got contrast, one didn't. The creatinine levels often go up more in the patient who did not get the contrast. Another article, McDonald. Intravenous contrast material administration was not associated with excess risks of acute kidney injury, dialysis, or death, even among patients with comorbidities reported to predispose them to nephrotoxicity. He goes on to say diminished GFR is associated with increased risk of serum creatinine-defined kidney injury following CT. However, it's an independent factor even in patients with GFR less than 30. Lots of interest in figuring out ways perhaps of having more patients be able to get contrast because I think we overestimated the risk. Some people say in borderline patients, one thing to do is make sure the patients are adequately hydrated. We use water. Patients drink a lot of fluids. But if you really need to hydrate patients, one protocol that the ACR manual suggests would be 0.9% saline at 100 ml per hour, beginning 6 to 12 hours before and continuing for 4 to 12 hours after contrast. Now, the problem with that is, of course, you're talking basically about almost a full day. On a hospitalized patient, that is indeed possible. On an outpatient, it's not. Other prevention strategies, minimizing contrast volumes, become very important. Hydration becomes very important. Avoiding nephrotoxic drugs. We also, for a while, were looking at some prophylactic pharmacologic agents, statins, N-acetylcysteine, but those really have not proven to be that successful and really have gotten out of favor. The other thing is consider the choice of contrast material you're using. So our principles at Hopkins, under 1.7 or so, with no other factors, we use Omni 350. 1.8 or better, we're using Visipake 320. We also use Visipake in diabetics, patients with history of renal disease, for cardiac CT, PE studies, older patients, pediatric patients. We routinely will use Visi 320. So again, you need to have some sort of protocols or institution where you use different contrast agents. There's no doubt that if cost wasn't an issue, I think everyone would use 100% of Visipake 320. It gives great comfort to the patient. There's very little side reactions. Omnipake works very well also, but Visi has that extra level of protection, and that's been written about in many different articles. So that becomes our protocol and how we do things. Now, there's several practical things with contrast I also should bring up. Do you use a warmer? If I asked the question 10 years ago, everyone kept their contrast in a warmer. But because of some JCO issues, most people now don't have warmers. Well, why don't you use a warmer? Well, you need to purchase a warmer. JCO now requires you to monitor the warmer. You put it at, let's say, 35 degrees. They want to know is, are you monitoring it? Maybe you went to 27. Maybe you went to 47. How do you know? Also, when you put contrast bottles in the warmer, you need to label them. And what JCO wanted, and people got cited with this, but I spoke with JCO and they said do it this way. Typically, you would say today's May 29th, you would write May 29th. They don't want that. They want you to treat contrast like milk. Put down June 29th, 30 days later. And so if you pick out a bottle, you're supposed to look at it. It says June 25th, and you're on June 28th, you have to throw the contrast away. So that indeed becomes very important. Now, it's interesting, there have been several articles that show that for faster injection rates, warming the contrast becomes important. In this article from Duke, tripling of extravasation and overall adverse events occurred when you did not warm the contrast material. So that is alone a great reason for warming contrast material. Less reactions, less controversy, less extravasations, less problems. So our thing is get a warmer, use it, monitor it. It's great for patient safety. There is absolutely no downside, and warmers are indeed very cheap. Now, what else? What patients do I worry about? If someone has lots of allergies, I do worry about them. Just because patients who have allergies, have other allergies. Shellfish, seafood is not going to be a problem. ACR manual, there's no evidence to support the continuation of this practice, worrying about shellfish. The manual does say that patients with significant cardiac disease may be at increased risk for contrast reactions, both symptomatic and asymptomatic patients. So those are patients probably we should pay more attention to. A question, how do you deal with patients with prior contrast reactions? Now, one of the things I need to find out from the patient is what was their reaction. Sometimes patients say, oh, I felt really warm, or I felt funny. Well, or I felt nauseous. That's not a contrast reaction. That's part of the contrast experience. And we tell patients not to worry. So you need to really figure out what the issue was. Now, the other thing is if someone said to me, well, all I remember is I arrested and there was a team and I was in the hospital for 2 weeks. Well, I will tell you if the patient had a severe reaction to contrast, I will not be giving IV contrast material to that patient. Now, in patients with reactions that are in between, some hives, things like that, then we pre-medicate. Our pre-medication protocol is 40 milligrams of oral prednisone at 24, 12, and 2 hours, and you may give Benadryl for 30 minutes before. Other protocols, like in the ACR, this article by Davenport, talk about 13-7 in 1 hour of 50 milligrams of prednisone and then the Benadryl. When I speak to the people in allergy at Hopkins, they tell me for prednisone to work, it needs to be on board for 24 hours. So we've had very good luck with the 24-12-1 protocol, and that's what we use at Hopkins. So it's very, very important. Now, a question is, if a patient had a reaction and you pre-medicate, what's the chance of another reaction? Well, this article by Davenport addressed this question. The majority of patients, 88% with a prior reaction, did not have a subsequent reaction. So 12% of patients had a subsequent reaction, but these so-called breakthrough reactions are more likely to be moderate or severe with certain risk factors, and that risk factor is patients who are on long-term steroids, but in most cases you get the same exact reaction. So again, it's very, very important to be aware of that. So if the patient had a few hives, 88% chance they're going to get no hive, 12% chance they will get a hive, but it'll be the same. The fact that your breakthrough reactions are the same, that's why someone who had stridor, I would not give contrast because their breakthrough reaction would be the same. Now, one of the questions about reactions that's often brought up is we typically know that most reactions happen at the time of the study, usually within 5 minutes, but other reactions happen later. I used to think later meant 30 minutes later, but the fact is many patients or some patients are going to get delayed reactions, and that's defined as an adverse event occurring more than 30 to 60 minutes to 1 week after contrast administration. The majority are 6 to 12 hours. Now, I remember we used to get calls, I have a rash, it's 4 days after my CT, I would say it must be something else. Well, it's important to know that patients can get delayed contrast reactions. They're not as rare as we think, and they're often falsely ascribed to other drugs or other things. These side effects are problematic because the patient is usually without medical supervision. If a patient reports a rash a couple days later, we'll either ask them to see their doctor or to come in and see us. And again, that's really the way to do it. The ACR really states that most of these delayed reactions are self-limited and require minimum therapy. But again, patients may need to have therapy, and it's really important to be aware of that. Now, the other thing with contrast, which hopefully never happens, but will happen in your practice, is IV extravasation. I said you need to be careful, you need to watch the injection, but somehow extravasation still occurs. It occurs very infrequently, fortunately, but it does occur. So the question is, when it happens, what do you do? Who do you call? What are the key parameters in patient management? And when do you need plastic surgery? Well, it's interesting. There are a lot of different thoughts about what you need to do. The ESUR has some guidelines, and their feeling is that in most cases, conservative management works. That means limb elevation, applying ice, and careful monitoring. If there's a serious injury, patient has symptoms, loss of feeling, then you need a plastic surgeon. And it's worth reading, and here I give you a place to look at their guidelines. Other articles come along. This was a pediatric article, which was kind of interesting. You know, we always have the question, do you give ice or do you use heat? And this article, everyone elevates the extremity. This was in the pediatric survey. 76% use heat, 76% use ice, and 45% use heat, which means some people are using both. I think at the end of the day, you need to elevate the extremity. That's what's critical, and there's no clear evidence to favor ice or heat compresses. So we tend to use ice right away, and then after 12 hours use heat, and that may be the best thing to do. The last thing let me touch on, since we're talking about practice guidelines, is in your practice when you report CT, are you using templates? Templates are something the ACR is pushing. Some people love templates. Probably your residents use templates. There are advantages and there are disadvantages about structured reporting. There's articles that say referring physicians prefer them. Then there are articles that say referring physicians hate them because the report becomes so long, they want to know what the bottom line is. Different articles. We mentioned this article on the pancreas before, looking at how to report pancreatic cancer. And this article made some very good points talking about the fact that there's so many ways people report pancreatic cancer. What if we had a standard template? This would allow comparison from institution to institution, looking at different therapies, looking at different outcomes, providing the information that the surgeon would want in a complete, pertinent, and accurate report. That sounds really good. And this article by really Al-Hawari and Isaac Francis really was very good at looking at the whole process, and not only just saying how the report should be structured, but the entire process should be structured. And this lecture, I spoke to you about scan protocols, and this very nicely shows you what you need to do. You need the scan protocol. You need to understand how to report things. So in pancreas, we look at arterial and venous involvement. We look at extrapancreatic disease, and all the information, how we report things, is all written there. Another article recently talked about structured reporting in pancreatic cancer, that surgeons were more confident regarding decisions about tumor resectability when they reviewed structure reports before review of multiphasic CT images. That surgeons had sufficient information for surgical planning in 96%, 69%, and 98% of structured reports, and only 31%, 43%, and 25% of non-structured reports. And they liked it better. So perhaps the structured reporting will come along. Now, one of the things also in terms of protocols is not just doing the right study and doing the right thing for the patient, but also it's a way of doing quality assurance. Protocol review plays a critical role in CT quality assurance, but large numbers of protocols and inconsistent protocol names on scanners and in exam records make this a problem. There's a really good article by Zhang that made the point that on their scanners they found so many protocols, and often the protocols were redundant. They were just added on new protocols. You might have 6 pancreatic protocols, 7 liver protocols. Well, again, the thing we made, the point, this article says duplicated, outdated, and rarely used protocols in the scanners were easily pinpointed when you categorized and cataloged all your protocols. So again, you want to make things more efficient. If you have too many protocols, if there's 5 different pancreas protocols, the technologist may pick the wrong protocol, and then you do the wrong study. So again, going back to the fact that you need to review your protocols once a year, they need to be trim, they need to be well done, well defined, and that'll make your job and everyone's job better and improve quality of care for our patients. So concluding then, protocol design is the key to a successful CT program. The steps up to reading the CT scan are what defines a success. You notice in this talk, I did not speak about how we read the studies. I spoke about everything up to the point of reading the studies. Without a well-defined program and process, your CT program will not stand the test of time. So if you're not doing what I suggested, there's never been a better time to start. And with that, I thank you for your attention.